Recording?
Yes.
Okay, so good evening to all of you. Thank you for joining us for this fourth and final mini-series, Zoom, webinars, whatever you want to call it. We hope you have found it interesting so far. Tonight we have a very special guest that I'm sure you will very much enjoy. Before we start to introduce Dr. Hen Sela, I would like to say hello to Rachel and all our US friends, colleagues, to Carol. I know Carol, I've seen you somewhere there. So you again, Carol from Mexico, Simi from the UK and all her team. Of course, everyone and all their teams. Lisa Colt in Canada, and again, our Australian friends who will probably listen to this tomorrow. So thank you so much to all of you for getting the word around and getting all our friends around the world to join in tonight to listen to this presentation. So if you enjoyed it, let us know and we will try to organize a few more Zooms like this in the near future. Okay, so this is how it works. You start sending questions. You can start sending questions along and I will pass them on to Dr. Sela towards the end and he will respond to your questions. So I would like to introduce Dr. Sela, Hen Sela, who is very interesting. I have to read off because there's so much to say about him. So first of all, he is director of the Shapiro-Hochstein Maternity D department. Okay, so he's a graduate from Ben Gurion University in Beersheba. He also did a subspecialty in maternal and fetal medicine at Columbia University. That's why his English is so perfect. Or from other sources, which I don't know about, but he might tell you about them. He also worked at Columbia University in New York as a senior physician and director of maternal and fetal unit. He is an expert in high-risk pregnancies, pregnancy-related illnesses like diabetes and other things like that, fetal deformities, C-sections. He is the king of the C-section. Every Haredi lady who is coming for repeat deliveries just wants him because he's very nice, not bad looking, and very friendly, apart being very professional, of course. He's also an expert in turning babies in vitro. Well, okay, placenta previa, fetal deformities. He's also the author of, or co-author and author of many research papers, which is very important for us at Shaare Zedek. We love our physicians to write many papers because we believe in passing on information and knowledge to future generations and training younger doctors. So he wrote papers on trauma during pregnancy, resuscitation during pregnancy of multiple fetuses, etc., etc. So he is going to talk to us about how it feels and how it is to work within his department with all these difficulties on top of the situation, the corona situation, and how this is challenging or difficult or whatever. So Dr. Sela, thank you so much for joining us. That's it. The platform is yours.
Audrey, I think after such an introduction, I think I should retire. I don't think I should start even. It was a wonderful introduction. Thank you very much. I blushed after so many years, I haven't blushed like this. So thank you. I'm really happy to be here today, and it's a pleasure to talk to you about obstetric in the time of pandemic. Those are indeed very challenging times. And I will start the share screen with the PowerPoint presentation that I've made, and we can go through some of the things. Just 1 second. No, not this one. So let's stop share. I'm sorry, it's going to take me another minute, hopefully, and we're going to be fine. No, this is not the one. Everything takes time these days. Yes, this is the one. Now we go back to Zoom. It's a new thing that we have to master nowadays. Okay, share screen, portion of screen. Let's see if that's the right thing now. Yes, it is. So again, good evening from Shaare Zedek in Jerusalem, and it is a pleasure, as I said, to be here tonight and talk to you about obstetric in the time of pandemic. And I'm going to talk to you Before I start, I want to state that I have no conflict of interest, and I want to share with you my gratitude to the entire medical and paramedical staff that are working around the clock to treat and to care for the COVID-19 patients and the rest of our patients in the hospital. Those are important things. I was going to say a few words about myself, but Audrey said too many things about myself. So I'll just share with you a few more things that to me, I'm happy to be here, but it's weird. It's the first time that I've been doing these talks in front of people after I haven't done it for, I think, since the fellowship. I did my training at Hadassah, and during my fellowship I did have some talks with the chapters of Hadassah Women in the United States. So it's been almost 7 or 8 years since I've done it. So please excuse me if my English is not superb, as Audrey said. And as a graduate of Hadassah and speaking to Hadassah ladies, it really is an honor to be here and speak to Shaare Zedek people. And I think that the purpose is the same, is to empower us to practice better medicine and to serve the people of Israel to have better medicine. With this, I will talk to you now about the importance of the topic. And the importance of the topic relies on the fact that pregnancy requires special consideration. We know that in every point of time, about approximately 5% of the women will be pregnant. And pregnancy is unique state in women's health. And there are physiological changes that occur, and those may impact how the corona present itself, how does it impact the disease, how will the disease impact the pregnancy, will it be associated with higher risk for preeclampsia, preterm labor, and so on, will it impact the fetus or the unborn child. And if we're looking of evidence from other similar illnesses, such as the influenza A, H1N1, the severe acute respiratory syndrome, SARS-CoV-1, and the Middle East respiratory syndrome, those viruses suggest that pregnant women are at a greater risk for severe maternal and also neonatal morbidity and mortality. So we were initially concerned about, what's going to happen with pregnant women. And before I continue with the topic, I just want to show you what I'm going to talk about. I'm going to be covering information about what's information do we have? How can we treat women if we don't have enough information? Which information did we have at the beginning of the corona, and what do we have now? And we're going to talk about our pregnant women are at increased risk of getting the COVID-19. And if they do they have a more severe form, or do they have like the rest of the population? Does it interfere with pregnancy? That it causes, as I said before, preterm labor, preeclampsia, diabetes, or other complications, as we know that other viruses can cause it? Can the unborn child be affected and have problems due to the virus? And how does it change our practice in terms of caring for regular women without the corona? And throughout, I will share you stories from our experience at Shaare Zedek. So I'm going to start, and I'm going to talk to you about what information do we have. And the search engine that we use for looking at the literature in medicine is what we call PubMed. And when we did the PubMed search at the beginning of May about COVID-19, we found more than 5,000 publications regarding corona overall. When you add the term pregnancy to it, we had only 100 publications. So you have to understand that when we cared for these women at the beginning of the pandemic, we had very little information about what it can cause, how should we treat them, can they get some of the medication that we're giving regular patients, or can we not? And it was quite challenging. Nevertheless, organizations have provided us with guidelines. We have the CDC, the Center for Disease Control in the US, have issued guidelines. The American College of OBGYN have issued guidelines. And also the Royal College of OBGYN in the UK also provided us with guidelines. Now, in order for you to understand how situations have evolved so fast, is we can see that the sixth version of the Royal College was already published on April 3rd, meaning in 3 months, sixth version of how to treat pregnant women was developed. I gave a lecture about this virus during the pregnancy on May 18th to the hospital staff. And I looked up the literature, and at that time we had only 4 series that I could rely on. one of them from China, 118 patients, and you know that we're doubtful about data from China. Italy had 42 patients, New York 43, and a systemic review that compiled all kind of case series, case reports together, 108 patients. So again, we were slim on what we could use in order to treat patients, to care for them, and counsel them. Nevertheless, I did the same literature search a week ago preparing for this topic, and nowadays we have 36,000 articles, publications regarding corona in general. That's amazing. And we do have 613 publications regarding corona and pregnancy. Now, I'm trying to keep up with the literature because that's my day-to-day work. And I must tell you, it's hard to tease out from all this lot of publications the real things that we need to pay attention to. So, but we are doing it. And when we do it, there are two publications that guides us very much. One of them is from the United Kingdom. There is a national population-based cohort, meaning they took all patients that were reported to have corona and admitted to hospital and pregnancy. That were 427 women altogether. And this is more than what we had in the first stage from four different series. And the US also reported, the CDC reported of 8,200 pregnant women with corona. So this is what guides us nowadays when we can counsel these patients and treat them. And of course, the national guidelines have been updated accordingly. So the questions that I started with are pregnant women at increased risk of getting the COVID-19, and the data is limited and conflicting. If you look at one case series from China that included 118 pregnant women over 3.5 months period with the corona, apparently pregnant women were 1 out of 500 patients with corona was pregnant women. So if you look at 500 women with corona, only 1 out of them were with corona. If you look of 200 women that came to delivery, only 1 out of those was pregnant with corona. So if you see this number, you say, well, why this is not a big issue. We can care for those women even if we don't know much. But if you look at the CDC report, which is much larger, this was as of June 16, and I am sure that the numbers have increased since then, more than 2 million cases of corona in the United States. And they had data on pregnancy status for 81,000 women at the reproductive age that were 1/3 of all women at reproductive age. So we have some bias because about 180 women at the same age, we did not know if they're pregnant or not. And apparently 9% of the ones that we knew that they were pregnant or not were positive for corona. And this is higher than the 5% number that we quote that pregnant women are at any point of time. Given the fact that some centers in the United States screen all pregnant women, if they come into, they walk into the hospital, they have a screening, and therefore it increases the chance of, having pregnancy with corona. I think that most likely pregnant women are not more or not less. They're about the same proportion of women in the population. What about the manifestation? Is it more severe in pregnant women? Does it has a different manifestation? And as I said before, our initial assumption was that pregnant women would have a more severe form of the disease. Aside from the physiological changes that occur during pregnancy, and this is related to a reduction in immunity or less lung reserve and higher oxygen consumption, we also know from previous flu pandemics that women, and if I take, for example, the 2009 flu pandemic in the United States, that pregnant women were 1% of the population. However, there were 6.4% of the population that were admitted to the hospital and 5% of the overall mortality. So they were, even though they were 1%, they were more hospitalized and more mortality. So we are concerned that that would be the same with the corona. Let's talk about their symptoms. And we see over here that this is the UK series out of 427 women. A lot of them had fever, a lot of them have cough and breathlessness, okay? Other symptoms are not as common, less than 50 out of 427, such as headache, lethargy, limb or joint pain. So those are not very common symptoms. But if you see somebody with fever, cough, breathlessness, we have to think about corona in pregnancy as well. What the CDC done, they've compared the symptoms in pregnant women to non-pregnant women. And again, we can see that the cough was present in 50% of the pregnant women and 53% of the non-pregnant women, and fever was 34% of the pregnant women as opposed to 42% of the non-pregnant women. Now, one thing we all try to relate to, and if you're not feeling that well, you're saying, oh, do I smell? Can I still smell? Can I still have a good sense of taste? And then we are, reassured we don't have the corona. Well, I think we're false reassured. And the reason for that is that we look at the new loss of taste or smell for women, pregnant women and non-pregnant women. Only 1 out of 7 women lost their loss of taste or smell. So this has a very a low sensitivity for corona. We shouldn't rely on loss of smell and taste. What about how they manifestate the disease? Is it more severe? We know that among the general population, 81% of the population will have mild to moderate disease. About 14% will have a severe form of the disease, and 5% will be critical. And if we look at the early reports from, as I said before, the small series of 100 patients, 40 patients, the rates were very similar. I would say about 85% of the pregnant women were mild, about 10 to 15% were severe, and very few were in critical care. However, when we looked at the CDC report, they looked at something very interesting. They looked at a proxy for severe disease. And a proxy for the severe disease was the admissions to the ICUs and mechanical ventilation. What they did adjusting for various factors such as age, other comorbidities, race, minority. And then they found that pregnant women have a much higher rate of being admitted to the ICU's intensive care unit, almost double the rate that the non-pregnant women, 1.5% versus 0.9%. And also the rate of mechanical ventilation was almost double, 0.5% as opposed to 0.3%. So I must tell you that I trust more this large report from the CDC, and it is our impression, not just myself, that pregnant women, if they get the COVID-19, they get it more severe. What about maternal mortality? So the maternal mortality rate all over the world is roughly, we say in Western world, and Israel is one of the places where the maternal mortality is very low due to, I must admit, I've worked in the States, I've worked in other hospitals in Israel. The maternal care women get here is superb. And the maternal mortality in Israel is about 5 maternal deaths per 100,000 deliveries, pregnant women. If we look at maternal mortality due to COVID-19, the first report was only on April 11th. The pandemic started on December in China. First report was on April 11th from Iran, and people were doubtful because it was the first case. After 4 months from other places in the world, there was no report. Shortly afterwards, at the end of April, another case series of 7 cases. And, people were doubtful, but I read the article, and apparently they described, honestly, women who died. And the care that they got was similar to the care we give over here and is acceptable all over the world. That raised some concern. And later on, only recently, the CDC has reported 16 deaths in the US, and the rate of death is 0.2%. So 1 out of 500 pregnant women with corona will die. The good thing, if you say good, you can't say good about mortality, but the rate is similar to the rate of non-pregnant women at a similar age, 0.2%. So pregnant women, even though they get it more severe, they don't have higher tendency of dying, and that's reassuring. However, when we looked at the UK data, 5 women died. And if you remember, the case series was a lot smaller, 427 women. So the case fatality is 1.2%, meaning over here, it's 1 out of 100 women died in the UK. This is high rate, specifically higher than the 0.2% in the CDC. But, I looked it up. I couldn't find a rate for pregnant women, non-pregnant women of similar age. But the crude rate of mortality in the UK I was astounded by that. There's 46,000 mortalities in the UK and a little bit more than 300 people who got the corona. So it's a 15% rate of mortality in the UK. I was shocked by that. So the rate in pregnancy is much lower, but we know that younger age and the female gender are protective factor for severity and death. So I can't compare those two. Now, in the UK, they also reported the rate of maternal mortalities, and they calculated the rate to be 6 per 100,000 maternities. If I take this rate and I take it to Israel, it means in Israel we have almost 2,000 deliveries a year. It means that we'll have 11 women dying each year from corona. If I take it to Shaare Zedek, as we have more than 20,000 deliveries in both campuses of Bikur Cholim and Shaare Zedek, then we'll have 1 woman a year. Fortunately, up to now, I'm not aware of any death, neither in, of course, in Shaare Zedek, but not throughout Israel for pregnant women with the COVID-19. So we spoke about, how corona impacts the mother, the disease, but can it impact the pregnancy itself? And first, let's start with early pregnancy. And this is the first report that was published at the end of April of a 19-week woman, 28 years old, first pregnancy. She presented with typical symptoms of COVID-19. The minute she was presented with typical symptoms, she had a swab test and it was positive. All therapy as needed to be done was initiated. Nevertheless, it ended sadly 2 days afterwards. She had contractions and she delivered a dead fetus. The entire examinations or workup that they had for her was negative, aside from corona from the placental side of the baby's side of the placenta. They had marked inflammation of the placenta, and they concluded that most likely that the virus went through the placenta to the fetus, caused what we call septic abortion and the death of the pregnancy, losing the entire pregnancy. And this is the first report. Now the question is it the norm, or is it not the norm? And when we look at previous case reports from the previous viruses, such as the SARS-CoV-1 or the MERS, Middle East Respiratory Syndrome 1, they have not demonstrated significant relationship between infection and miscarriage. So this is reassuring because the virus is similar, one thing. The second thing, this is one of the unique case reports in this regard. So we are kind of reassured, even though we don't know enough, but we tend to think that most likely there is no increased risk of a miscarriage. But we have to understand that, women, first and second trimester were not that investigated. Now, other question is, will it cause fetal growth restriction? And currently we don't know. However, and the reason we're concerned for is, again, because if we look at the SARS-CoV-1, 2/3 of the women that had SARS-CoV-1 had a fetal growth restriction, meaning a small baby inside the uterus. And a small baby has a higher risk of having born small, have more complications than neonate, even intrauterine fetal death. So that's a concern. Therefore, currently the recommendation is that women, if they can, consider not to conceive until more data will be available about the safety in first and second trimester. We do not know about a similar effect like the Zika virus or the CMV virus or the rubella virus that we know that can cause malformation to the baby. So far, there haven't been reports of malformation due to the COVID-19. What about later on in the pregnancy? So as I said before, initial reports were 118 patients, 42 patients, 43, 108. And when we looked about the deliveries, it was even less, 68, 40, 40, and 100. And apparently what was striking is that the rate of C-section was extremely high. The rate of C-section from China was 93%. The rate in Italy and New York was roughly 43, 44%. And again, China, 92%. So this is extremely high. In the US, the rate is roughly 30, 34, so it's increased. In China, it's 50 to 70%, it's increased. And indeed, when you read the articles, then they specifically state that 50 to 60% of the C-section were due to corona. So it makes you wonder, and when you treat Orthodox women, or women who wants to have multiple births, having a C-section sometimes might limit them, might expose them to have future C-sections, and this could be a somewhat troubling. The other thing that we looked at, and it was striking, is that the preterm delivery rate was 21 to 28%. And overall over the globe, the preterm delivery rate is less than 10%. It is about 7% in Israel. So this is like triple or 4 times the rate of a preterm delivery. And preterm delivery is not just a statement. Preterm delivery means that the neonate is being born early. Neonate that is born early does not have his systems working fully functioning, has a higher risk of having intellectual disability, lung problems, kidney problems, and so on. So definitely we do not want that. Also regarding the C-section rate, these rates are high. We know that in Israel, the C-section rate is roughly 20%. At Shaare Zedek, it's roughly 12%. And I will share with you some information about our C-section rate in the corona patients shortly. What do we know from the last report about 427 patients from the UK? So overall, out of 427 women, 266 completed the pregnancy, so we have data about them. Reassuring, 97% had a live birth. So that's very reassuring, meaning that most women with corona will give birth for a live baby. However, 26% delivered less than 37 weeks. Fortunately, the majority of them delivered what we call delayed prematurity. So they have some effect of prematurity, but not significant. However, I would say that about 10% of those did deliver at extreme prematurity, which is associated with severe morbidity. Mode of delivery, only 1 out of 3 women delivered what we call unassisted vaginal. In Shaare Zedek, 85% of the women currently delivered in an unassisted vaginal, meaning no C-section, no vacuum, just regular vaginal delivery. So this is extremely high or low rate of unassisted vaginal delivery. And the rate of C-section only due to corona was 16%, again, high. So I think, what we can tell up to now is that pregnant women with COVID-19 might get a more severe form of the disease, one thing. The second thing is they're at high risk of having a preterm delivery, which has impact on the baby's health for future health. And they have a higher chance of getting a C-section due to the disease, and we're going to talk a little bit more about it shortly. What about, can the fetus or neonate be infected during the pregnancy, delivery, or breastfeeding? So we spoke about the one case report of a miscarriage, but if you don't have a miscarriage and you just had an infection, it resolved, can it get to the baby or not? And most tests on neonates upon delivery are negative. And this is an example for a case series of 116 babies with corona. Of those, 186 were tested upon delivery for the virus and were negative. So this is very reassuring. Also, I have unpublished data from my colleagues in Tel Aviv. They did an amniocentesis for different, medical reasons that we do for pregnant women. And they tested all amniotic fluid for the virus, specifically for women that had evidence of serology positive, meaning that we knew that they had earlier on the virus, and everything came back negative. So we are quite reassured that most likely, if the woman had it and it resolved, it does not pass along to it does not go to the baby. It's very reassuring. What about during delivery or during breastfeeding? And several studies have been done, and most of them does not show the virus in the human milk. And however, there are 2 cases in which the virus was detected in the human milk. There are some critics that say, well, it could have been a contamination. It is not really an infection of the human milk. It does not come from the mother. It was an outside source. But we'll speak in a minute about what's the recommendation regarding breastfeeding. And, I don't know if it came from in utero or during delivery or after delivery when the mother handled the baby. But when we looked at of those 265, this is the largest case series from the UK, we see that 95 of the babies were negative when they were tested after the delivery. However, 6 neonates were less than 12 hours were positive, and another 6 were positive after 12 hours. So overall, the rate of infection of neonates, whether it's during labor, after labor, or before labor, is really small. And also what is reassuring is that all these babies that were tested positive in this case series and other case series or case reports had mostly mild disease and all have recovered, totally recovered after a while. So we don't know, currently we don't know about long-term impact of neonatal disorders of the COVID-19. So that's reassuring as well. Regarding breastfeeding, because the data about human milk is so skim, and we only know about 2 cases where the human milk was positive, and breastfeeding or mother's own milk, as we say, is the best thing, is the best food for the baby. All major organizations like the World Health Organization, the Center for Disease Control, the Royal College of OBGYN, the American College of OBGYN, all of them recommend either continuing or initiating breastfeeding for women that are positive for the virus. However, the mother should practice respiratory hygiene, wear a mask, wash hands before and after touching the baby and caring for him, and cleaning the entire area where she's caring for the baby. Now, so far I gave you a lot of information, I think, but we know that this all information also raised practical implications to us. How should we care for these pregnant women who get the virus? How should we care for women without the virus? How should we run labor and delivery? Should we separate between women? How can we separate between women? Can we do it just based on where she's coming from? It's a red area, so should be separated from other, or should we screen women? And that's the triage room. If we have women that we have a concern for corona or she's known corona, how can we do a C-section on her? And many more questions, which will give you some things of how we do it over here at Shaare Zedek. But the 2 main principles that guide us are 2. One thing is we are certain that multidisciplinary team approach for the women with COVID-19 is the way to go. We consult our infectious disease team, which is, I must admit, again, they're amazing. They're available 24/7 for any question, professional, personal. They're amazing, really. The OB team, the maternal fetal medicine, and again, from Professor Grisao, the chair of the department, all attendings are available. Anesthesia team, Professor Yoskovich, neonatology, from everybody is available. And in difficult cases, we do consult and we do make decisions together. That's one thing. The second thing is in severe cases, the mothers comes first. If she needs a workup, a CAT scan, even though it's radiation, we'll do it. If she needs medications, we of course try to give her the safest thing, but we don't compromise her health. And therefore, there could be a situation in which we'll deliver a baby preterm because the mother's health comes first. Let me walk you through some of these practical implications. So some have suggested a universal screening due to the fact that as much as 10% of the women that we will screen will be positive. About 80% of those are asymptomatic. And this is a study from the US, 3 hospitals in New York City, 675 women, 10% positive, 80% of the 10% were asymptomatic, no symptoms whatsoever. And we know this could be advantageous if we do it. You don't put her in with somebody else's room. The healthcare worker who cares for her use better precautions and protection. The mother is instructed to use better precautions when she's breastfeeding and so on. However, in practice, when you screen these patients and you do mass screening, you can't do rapid screening. So the results come back after 24 to 48 hours. So what do you do with women who were rooming in with those patients? What do you do with hospital or care provider that took care of her? And also the results is as good for the time that you checked her. If she had symptoms afterwards or she got infected later, you don't know about it. So there are downsides to screen all. And the other alternative is to screen based on risk factors, symptoms, exposure. And we know that there are risk factors for illness, such as minority, ethnicity, obesity, comorbidity, and so forth. And if you do risk-based screening, then usually you can use the rapid screening. And the rapid screening will give you a result within 2 to 4 hours. So you can isolate the person that you're thinking that might have the corona until you get the result. And then you act upon it. For example, this morning we had a woman coming from hospital, self-quarantine after 8 days because her husband had it. And she was in labor. We put her in a separate area in labor and delivery. The midwives and the doctors who care for her used the personal protective equipment, as I'll show you in a minute. And we took a rapid swab, and we got the results after 4 hours. It was negative. She was moved to the regular labor and delivery, and we could treat her as a regular person. Now, we cannot do it for all women who are coming in. So currently in Shaare Zedek, we do only, when it's indicated, we do the screening for women who come from home quarantine, recent contact with positive persons, or women with symptoms. And this is the vast majority of hospitals, that's what they do. When we speak about a personal protective equipment, then during all encounters, women are encouraged, and also escorts, they use and they wear surgical masks. And it's a continuing effort. You know, having this, trying to push through labor with a mask is hard, but you know, that's what we have to do. The provider uses gloves and surgical mask. If the woman is suspected to have the virus, as the same woman that I just described a minute ago, then the provider also uses gown, high shield, and instead of a surgical mask, we use a N95 mask. What happens when we're caring for a positive woman? And this is myself. A week ago, we had a patient that was admitted to the Corona department, the Crown department. She was 38 weeks. Her previous pregnancy, she had a C-section for a breech baby. And this pregnancy, she was admitted at 38 weeks with respiratory syndromes, abdominal pain. She was cared for at the Corona department, as I said. She got O2 and oxygen support and some pain medications. And over 3 days, she kind of felt better. We were thinking of discharging her for home quarantine, and she started to have contractions. I'll show you in a short while a picture of how it looks labor and delivery at the Corona department. But essentially, it's a much smaller room. We have a monitor that we can see from far away. But if in case we need an emergency C-section, it's very hard to do it. We have to dress ourselves the way I dress over here. We have to move her to an operating room with a negative air pressure so we can do it. We have to protect the nurses, the doctors, the neonatologists who come to care for the baby. It takes time. So when you have a woman at a high risk of having a problem, such as a woman with previous C-section, we talked to her about it, and she decided to have a C-section. We took her for a C-section. Now you can see I'm wearing the scrubs. I wear a gown. I wear this white, this white coat, which is rubbery, so you sweat all through it. I had a face mask. I had my own glasses, the shield, and a cap. That's how I operated her. I had to dress, take her to the OR. Altogether, it was like this for 2 hours. This is how I looked afterwards, wiped out. And really, after this experience, I really take my hat to the entire team who work every day at the Corona area. So this is how we dress when we care for women that are positive. How do we care for asymptomatic women? So as I said before, the vast majority of them will have mild disease, and means that they don't need any imaging, no chest x-ray, no CAT scans, no treatment, and the women should be managed at home. They should be reassured that they can do it at home, self-quarantine. We should postpone all non-urgent care until we can do things. Now the question arises, should we perform more testing on the mother and baby during the pregnancy? And this is a quote I found and so I'll say it out loud. One would intuitively intensify maternal fetal surveillance, but the potential benefits of such measures need to be balanced against the risk of viral transmissions to the healthcare worker and other patients, and the increased burden on already overstretched healthcare services, and I must add, without a proven benefit. Therefore, currently we do not do that, but when time goes along and we'll have more data, Maybe we will need to do it, I don't know. How do we care for symptomatic women? So I think the principles are, first, we have to tailor the treatment to the specific symptoms and with multidisciplinary input, as I said before. The mother's case comes first. Having the virus itself is not an indication neither for preterm delivery or delivery by itself. We have to see if the mother is coming back to herself and she's recovering. Wait, hold. And it's hard for doctors to sit on their hands, but that's important. Care should be provided in a facility like Shaare Zedek that has the capability to conduct close perinatal monitoring, and low threshold is suggested to transfer to the ICU. And over the last 2 months, we had, I think, roughly 5 women that were admitted to the ICU, the Corona ICU, due to worsening respiratory syndromes, and they were cared by the intensivist, and they recovered and they recuperated, and they're at home. Vaginal delivery is not contraindicated, and unless maternal medical condition would worse and will mandate either for the baby or for the mother. And if there is an indication for a C-section, we should do it as I showed you before. What about postpartum after the delivery? So more women are asking for rooming in. Women are concerned that the baby is going to be in the nursery with other babies. Other people are going to come in. And, you know, all in all, I'm in favor of it. I think that rooming in is an excellent idea. However, we do have limited numbers of room available, and we are trying to accommodate whoever wants it. More women are asking to be discharged early, and we have some regulations by the Ministry of Health that we can only do it after 36 hours. We have worked with our neonatology team to do it less than that. Any woman, of course, that any woman with symptoms or fever is being checked for the virus itself, so we can, you know, care for her safely and for her roommates. I want to touch upon 2 more things, you know, and does the virus impact our routine obstetric care? And this was a review article by International Fetal Medicine and Surgery Society. And a few things that they have noted. One thing is that pregnant women may be, in addition to their concern about the coronavirus, be anxious about not receiving the optimal antenatal care, which is important, we know, in certain conditions. And in general, we say that we should not change our routine antenatal care. We should continue doing routine antenatal care, although it can be modified. Some visits could be online or could be over the phone, over the internet, and this would minimize the contact between the individual patients and the healthcare worker. However, we should know that some women may not have the resources to do so. So we need to be open-minded and accept all women who wants to come and see us face-to-face. Certain condition that for me as a maternal fetal medicine is very important is, what about if the baby has a problem and we need to care for him? And most fetal therapies are time sensitive. If we won't do it, we might lose the baby. We might need to deliver the baby earlier than we can, and delaying this procedure may worsen fetal neonatal and even maternal outcomes. Therefore, we think that fetal therapy should not be defined as elective and should be done. In this busy slide, you don't have to see everything. It just tells us there are 11 diagnostic and therapeutic procedures that we do on fetuses and pregnancies, and this is considered fetal therapy. At Shaare Zedek Medical Center, we have the ability to perform half of those and we've done them in the past, even though some of the people who work in fetal therapy know to do more than that. And we are trying to expand, you know, our abilities, and those are extremely important to our population. People who want to do everything for the baby, improve their outcomes, are not considering to do termination of the pregnancy due to a malformation. And unfortunately, some of these patients need to be transferred elsewhere in Israel or abroad to have the procedure done. Example of these procedures, I'll give you 2 examples of women, is one of them was diagnosed at 32 weeks with fetal anemia. And it means the baby had low oxygen, and without treating him, we had to deliver him. However, we did a fetal intrauterine transfusion, the same as you give to an adult person. We gave it to the baby through the umbilical vein, and the baby felt better, the fetus felt better, and we were able to deliver him at 36 weeks. And this is a big difference in terms of neonatal prognosis. The second case is a woman at 21 years old that we saw her the first time around 13 weeks, and we saw that she had a twin pregnancy. The placenta had some blood vessels going from one baby to the other baby. And within a few weeks, she developed a situation which we call twin-to-twin transfusion syndrome. One baby gives blood to the other baby. Without treatment, both babies die. The treatment of choice nowadays, all over the world, and in Israel also, there are 3 centers that do it. And I've done it in my fellowship, and the other training that I've done in the US is laser photocoagulation. However, we don't have this technology yet at Shaare Zedek, so we transferred the patient to Tel HaShomer. She had the procedure done, and she came back to us. She had a follow-up, and she delivered 2 healthy kids at 36 weeks. So those procedures are life savings for these babies and these pregnancies. And those procedures are time consuming, resource consuming. And you have to ask yourself, during this pandemic, can we allow ourselves to do these things? Because it takes a lot of resource and time, as I said before. But the overall notion around OBGYN and fetal therapy centers and doctors who treat it, yes, it does, because it does save lives, and we do need to continue doing that. Regarding Shaare Zedek's experience, so under the leadership of the hospital and the department management, we have established several concepts. The care for the women on labor and delivery should not be different than regular times. As such, maximal effort is being made, again, through the leadership to have the same number of midwives, doctors, and the rest of the team, even though at any point in time we have midwives, doctors that are either sick or self-quarantine. Nevertheless, we're staffing our team all the time the same as it was before. The second thing is, given public fear of coming to the hospital, where corona patients are cared for, I think that the hospital PR made a lot of effort after the first few months of the pandemic to prove to the public that we are a safe place and that we practice safe medicine, and it is important to deliver at the hospital. You can see over here that during March and April and May as well, there was a reduction from 1,300 deliveries to 1,200, from 1,200 to almost 1,000. So we kind of lost 6 to 20% of the deliveries during the first months of pandemic in Israel, in Jerusalem specifically. However, during June and July, the numbers are quite stable. So I think we're able, through the efforts of the PR and the hospital team, to prove to the public that we are a safe place, and it is important to deliver at the hospital and in a hospital like ourselves. So that's really a big applause to the PR people. What else have we done? As I said before, we have established an area where we care for pregnant women with COVID-19. This is the Crown department, and they are cared for by multidisciplinary team. And it depends if the woman has more of an obstetric problem or a corona problem. Currently, today we had 2 patients. One of them has an early rupture of the membranes, puts her at high risk for preterm delivery and infection. So she's cared by our team primarily, and the corona are helping us, but so far she had no symptoms of the corona. And with another patient that was admitted with respiratory symptoms, and those are kind of weaning off, and we're thinking of discharging her tomorrow. The second thing we've done is there are designated areas in labor and delivery for women that are home quarantined, and they're treated over there. So far, we have cared for the first wave between mid-March and end of May, 2.5 months, for 10 women that delivered over here with us. And during the second wave, June and July, we had more than 20 women. 2 of those had fetal demises, and this is a concern. However, there are few reports in the literature. We do not know if it is related to the corona, if it relates to fear of women getting care, not coming to the hospital or to healthcare providers when they had a problem, and therefore things have evolved to fetal demise. And overall, we had 2 C-sections among those 20 patients. So we are roughly in the same rate of C-section. We have not increased our C-section rate. As I said, every day we have, or every other day, we have women with COVID-19 that is cared for in the Crown Department. I want to finish with one last story that to me just symbolizes the care that women get at Shaare Zedek. I remember the day I got a phone call on Monday morning, I think it was about 3 or 4 weeks ago, 10 to 8, by a midwife that's working with us. And she was calling me, said, listen, you remember my daughter? I said, yes, she's about to deliver. She said, yes, well, we had with them Friday night dinner, and yesterday we found out she has corona. And we had Friday night dinner with them. So I'm quarantined and I want to take care of her, and she's now in labor. Not just that, this woman had the previous brain surgery, the woman itself, the mother. So she's a high risk pregnant woman. And I want to be with her. We kind of worked all our way through the hospital administration to get approval for the mother, who was supposed to be self-quarantined, to come with her daughter to go to the corona and get cared for. And you can see over here, this is the gown that she's wearing, the same one I wore when I did the C-section. It's written on it, mother and also a midwife. And this is before the delivery. This is after delivery. She's holding the baby in her hands. Now, you remember I talked to you about the room, how small the room is. You can kind of feel the size of the room. And this is opposed to our beautiful labor and delivery rooms, thanks to you, that we currently have. So the birth experience is not as great as we want it to be, but I think it's as safe as we can get it during these days. And I cannot finish without the thank you of the mother, of the grandmother, essentially. She wrote to me an SMS or a message few hours after delivery. Please pass along my thank you for, and the images, to the people, the administration that have helped me so much. I cannot know how I can reach her. I have no words in my mouth how to thank you for the big efforts and the efficacious efforts that you've done to get me the approvals, to escort my daughter for her delivery, as she so much wishes for. We're all very much appreciative of all these efforts that have been done in such a crazy days, to take into consideration the emotional feeling of anxious delivering women. May you always be a part of joy, happiness welcoming the patients and the midwife's name and the entire family. I was moved. I sent it immediately to Sefi Mendelovich from the hospital administration. And I told him, I attach hereby the message from the midwife. I have no doubt in my mind that the hospital of Shaare Zedek is amazing, and for evidence is her gratitude to Ilah and the rest of the team that they allowed her, even though she was self-quarantined, to escort the daughter to the delivery. This is the summary. I think it's just repeating itself. So I think, I can thank you for coming today and listening to me. I hope I've enlightened you a little bit about what we're having or practicing on a daily basis, and I'll be happy to take any questions. I'm opening my phone to see if the questions are there. Okay, so the first question I see, should pregnant women avoid contact with general population, especially towards later stages? That's an excellent question. I think that currently we do not know of, as I said before, risk of the first and second trimester in terms of infectious miscarriages or fetal growth restriction. And there is no evidence that the baby can get it if the mother get it. Of course, so the guidelines nowadays do not say that women in the first and second trimester should be more precautious than the regular population. However, towards the end of the pregnancy, and we say 28 weeks and onwards, we do recommend that women would have more precautions regarding contact with other people. Any other questions, Audrey?
Okay, so we had a few other questions, but you've been so thorough with your presentation that you answered the questions before we could even ask them. So basically, you've done brilliantly. This was very, very informative. I'm sure everybody will agree. Very interesting. Love the pictures as well. God, this is like going to the moon. delivery suite is like landing on the moon or something like that. So I think that's it for us tonight. Thank you so much. Please continue delivering our beautiful babies at Shaare Zedek. We love them, and keep safe, healthy. And to all of you who joined in tonight, thank you so much. Please send your feedbacks to all the officers around the world. We're very happy to continue being creative during these difficult times and find ways to get to you. If it's through Zoom or other means, we'll do it with pleasure. So yeah, keep safe, wear your mask, wash your hands, and see you soon. Bye. Thank you so much to all of you. Thank you, Hen.
Thank you.